people on the call here, roughly? Anyway, I can see you here. You can all see me, and you can see my slides. Okay, so let's begin. So the topic, I was asked to give this topic because it's an area of interest of mine. I got involved in the area of capacity assessment many years ago when I got a cold call from a lawyer in Toronto who said he needed an assessment, a retrospective assessment of somebody's testamentary capacity. And when I got that call, just to put things in perspective, I had to ask him, what is testamentary capacity? I didn't even know what that was. Nobody had ever mentioned the term to me. And of course, it turns out to be is the capacity to make a will. And subsequently, I've learned simply by experience, not by any teaching, about the role of the medical expert in the area of testamentary capacity and related capacities. So this is an area that I think is of importance for specialists in geriatric psychiatry to know about, and yet it's very poorly taught, both in the medical school training and in specialty training. I don't know if you guys have had any specific training, even on capacity assessment in general, or certainly probably not in the area of estate litigation, which I will talk about as an important area for you to know about. Okay, let's move on. I'm going to try to keep within time so we have time for questions. So this is something you're obviously familiar with. I don't need to tell specialists in geriatric psychiatry about the prevalence of Alzheimer's disease, but I put this slide up. It's an old slide mainly from the Canadian Study of Health and Aging, showing the prevalence of Alzheimer's disease by age. The reason I'm showing this is I have a bit of a hobby horse on this topic, on this issue. People talk about the elderly today still. We are geriatric psychiatrists. How do we define geriatric? How do we define elderly? The common definition of elderly from an epidemiologic point of view in the lay press and generally is 65 and over, is elderly. And I'm arguing, especially at my age, we got to stop doing that. 65 and over is not elderly. This tells you that the prevalence of Alzheimer's disease in the 65-74 group is virtually the same as the general population. Why do we call 65 and over elderly? We shouldn't do it. If elderly means frail, if elderly has a epidemiologic implication of increased dependency, increased cognitive impairment, increased frailty, it is not the 65 to 70 group. It's not even the 75 to 80 group. Frailty and geriatrics doesn't really begin until, as a societal cohort, probably until about 85. So if anybody wants to discuss that later, I'm happy to discuss that issue, but I just wanted to get that off my chest. So why is this important? I'm going to talk about testamentary capacity today as an exemplar of all capacities. So there are many other capacities that we're going to have to address as specialists. Things like finite capacity to manage property, the capacity to grant and revoke powers of attorney, capacity to gift, what are called inter vivos gifts, that is, gifts during one's lifetime, capacity to drive. There are many capacities. I'm going to talk about testamentary estate litigation as an example of how you assess capacity and what the issues are related to capacity. The reason it's important is there's going to be an increase in legal challenges to capacity in the coming years. This is based on demographics. I showed you that slide on the prevalence of dementia or Alzheimer's disease. which increases not until you get over 85 in a significant way. But it's that very segment of the population, the very old, are growing at the most rapid rate. So the group most vulnerable is also growing at the most rapid rate. We know that the prevalence of cognitive disorder in particular in that group, based on the previous slide, is going up exponentially. While that is happening, the modern families are increasingly complex. Blended families, multiple marriages, step families, half brothers, half siblings. And with the economic reality that the younger generation of complex family structures is under great economic stress, while the very elderly are in fact about to make the largest transfer of wealth in human history. You know, it's true that there are many elderly people who are financially stressed, who are poor, but there's an awful lot of money in the hands of the very old that is about to transfer to the next generation. And that wealth is accumulated primarily by real estate properties, also by savings. So there's going to be, for that reason, this is what we call the perfect medical legal storm, a growing elderly population with a high prevalence of cognitive and mental disorders about to transfer the greatest amount of wealth in human history to a younger generation of complex families under economic strain. That is the ingredients for will challenges and disputes over estates. And we know that the last point is that if there is a contemporaneous assessment of a person, contemporaneous meaning while they're alive, somebody does an assessment and records that they are capable, it's virtually impossible to overturn that retrospectively when there's a challenge after the person has died. And you may be asked to do retrospective assessments, retrospective meaning using only medical records and other documents to go back in time and form a retrospective opinion. There are certain challenges and there are certain advantages to doing a retrospective opinion, by the way, but the contemporaneous challenge is going to be very difficult to overturn. Now, capacity, estate litigation, testamentary capacity, most capacities other than capacity to consent to treatment or MAID, is a legal determination, not a medical determination. The lawyers are going to have to help the judges make that determination. Yet, we're talking about mental functions. Capacity is a mental function, involves cognitive functions. What do lawyers and judges know about cognitive functioning? Very little. They need input from medical experts. So I'm going to talk more about the role, but it's important you understand that this is an important area of medical legal collaboration. It's not our determination. We don't decide whether somebody is got the capacity to make a will or make a gift. That's a legal determination. But if we know what the test is, we can help the lawyers and the judges make that determination. So what is the role of the medical expert? Well, basically you're offering a clinical opinion, not a legal opinion. So keep that in mind. Your job is to help the judge or the courts or the lawyers understand the nature or severity of any mental or cognitive disorder. That is in your area of expertise. We as geriatric psychiatrists can help the courts determine, is there a cognitive disorder? Is there dementia? What type of dementia? How severe is it? How does it impact on the specific legal test? And I put BVG for testamentary capacity. That stands, and I'll talk to you about that in a minute. It stands for the legal test that is the leading test in testamentary capacity, which is called Banks and Goodfellow. Just so you know, that is the test. We'll go into the details of what that test is. When you're asked about undue influence, I'm going to talk about that in a minute, your role as experts is not to be a detective and determine whether anybody was being influenced or not. It's to help the court understand how vulnerable is that person, how vulnerable emotionally, how vulnerable cognitively. You defer to the court for any facts related to influence, or for that matter, any facts, disputed facts related to a dispute. That's not the role of a medical expert to determine who's telling the truth, what the facts are. That's up to the court to determine. Okay? So what is the role of the expert? Well, in Ontario and in most provinces in Canada, an expert offering an opinion, a written opinion, for the court's benefit, has to sign or make a statement about their duty. And this is important because medical legal work has gotten a bad rap. A lot of doctors are afraid of medical legal work, don't want to do it. They're afraid of the court. They're afraid of getting sued. They're afraid of dealing with nasty lawyers in court. And that's because doctors historically have had a bad reputation about being hired guns. It is not the responsibility of a doctor to be a hired gun and say what the lawyer retaining you wants to hear. If you do that, you will be discredited immediately and have no future as a medical expert in the courts. The first duty is, in fact, to the court. It doesn't matter who's retained you, and often you will be retained and paid by one side in a dispute. But your first duty is to the court, and you have to sign an affidavit or make a statement to that effect. You swear that you're going to be fair, objective, and nonpartisan. Your job is not to argue the case. Your job is not to win the case. Your job is simply to do what I said before, provide the courts with as much information as they need or as possible. What is the nature, if any, of any mental or cognitive disorder? What is it? How severe is it? How does it impact on the specific test in question? And the other important thing is that you only offer an opinion within your area of expertise. Now, in general, capacity should fall into the area of expertise of any geriatric psychiatrist, or any geriatrician for that matter, or any cognitive neurologist for that matter, or any care of the elderly physician. There are many physicians who will have expertise in this area. So what's involved in a capacity assessment? This is the basic story about capacity assessment. It involves two underlying principles, all capacity assessments. Understanding of relevant facts, that's number one. Does the person understand the facts relevant to this capacity? And appreciation. Do they appreciate the reasonably foreseeable consequences of making a decision, right? That's the fundamental approach to all capacities. So even if you don't know what the test is, you really need to go back to first principles, understanding relevant facts, and we'll talk about what brain functions are necessary for that. The other important thing is that capacities are very task or decision specific. You cannot generalize about capacities. You can be capable in one area and not capable to make another decision. So you could be capable of making a will, but not capable of managing your property, or not capable of driving, or vice versa. It depends on the decision, and it also depends on the circumstances, what we call situation-specific factors. So you can two people making a will, but one is in a very complicated family structure, the other has got two loving children and wants to leave everything equally to the two children. That's a very different situation than somebody who's got multiple corporate holdings, who's got a blended family, whose family are fighting among themselves, making demands. So you've got to understand that capacity assessment is both decision specific and situation specific. I'm going to elaborate on that in a minute. It's not dependent on a diagnosis alone. You can have a diagnosis of Alzheimer's disease and theoretically still be capable. You can have a mental disorder and still be capable. Conflict and complexity in the situation of a person alters the threshold for capacity, and I'm going to show you some slides that illustrate that. Most importantly, when you're doing assessments of capacity, you need to not only know what the relevant facts are that the person has to understand. You have to know not just their specific situation, but you have to determine whether that individual, and this is very fundamental, can that individual give you a clear and consistent rationale or explanation for whatever decision they're making? If you can document that, you're halfway there to doing a capacity assessment. That's important. Can they communicate a clear decision? So, to summarize this, a cognitive test to determine capacity involves understanding factual knowledge, understanding the options that are available. I'm assuming, by the way, that you're going to have these slides available to you so you can go back and look at these. Do you appreciate the consequences, the potential outcomes of a decision? And can you communicate the rationale for those choices that you're making? That's the essence of capacity assessment. If you understand that, you can do capacity assessments. Communication is important because that's often a challenge, especially when there's evidence for dysphagia or aphasia after a stroke. Is this a cognitive issue or is it a communications issue? And you have to be able to determine that. So let's talk more about this situation-specific issue. I've created a paradigm, a graph that illustrates the changing threshold for capacity depending on the circumstances. So the y-axis in this graph is the level of cognitive ability from high intact cognition to low, or emotional stability for that matter, stable, unstable. And you can see that the outcome it's a binary outcome in law. You're either capable or you're incapable. There's no partially capable or partially incapable. A decision, if there's a dispute, we'll have to make a decision. Guilty or not guilty, capable or not capable. And I always struggled with, how does a judge determine where that line is between capable and incapable? And what you'll see here is that the green area, if you're in that part of the graph, you're capable. If you're in the red, you're incapable. But in between, the line is, I've actually tried to blur it a little bit. There is a bit of a blur where that line exactly is. It's literally a judgment call. It's a call that the judge makes, not that you make for most of these capacities, other than consent to treatment, for example. And you can see here in this graph, if you go up the y-axis to the top, and you see that you've got high cognitive ability and you're emotionally stable. If you go across the x-axis, which depicts the level of complexity in a person's situation or how much conflict is in their family, as you go along to the right on the x-axis, if you're up at the top of the graph, you'll see that you always remain capable if you're cognitively intact. Complexity doesn't make you incapable if you have intact cognition. However, if you go down the y-axis, let's say to the middle or lower, you'll see that when you have impairment of cognition, as you go to the right along the x-axis, you will reach the incapable side of the graph much sooner, because the level of complexity, you have to be able to discriminate between competing claims. If your executive brain function is impaired, if you're otherwise vulnerable, you will go into the incapable sooner if there's more complexity and if there's more conflict in your family. So that's the paradigm for how complexity, situation-specific factors affect capacity. Okay? I guess we'll leave questions till the end, I think, just for logistic purposes. Now, in testamentary capacity, I mentioned Banks and Goodfellow. This is, you can go back to, don't even try to read this slide. This is the statement from the original decision that was made in 1870, believe it or not, more than 150 years ago. In law, this is still the leading case. How many facts do we have, or how many things in medicine do we believe in that are still 150 years old? Not too many, but the law is different. They're stuck on a case in 1870. So what is this case? It's called Banks and Goodfellow, and this is a summary of what the test is for testament. So this is what you'd be assessing if you were asked to assess somebody's testamentary capacity. Number one, are they capable of understanding the act of making a will and its effect? You know what a will is? You know, a will is a legal document that determines how my assets are distributed after I die. That is what a will is. Frankly, most people will know that. And sometimes they may not know that, but they need some supportive decision making. A lot of people don't know the difference between a power of attorney and a will. And sometimes it just simply needs to be explained to them. As long as they can understand and learn that, they're okay. Two, are they capable of understanding the nature and extent of their property? That is the traditional test criteria. Do they know what their assets are that they're going to distribute in their will? But that's not good enough. We recently did a paper where we tweaked this, and I've added, you see in italics, yes, you need to understand the nature and extent of your property, but relevant to the disposition. So if you're leaving everything equally to your children, it's not as critical that you understand the details of your assets. However, if you're leaving a house to one child and $1 million to another child, you damn well need to know the difference in value between the house and the money that you're giving. So that's something that you need to explore when you're doing a capacity assessment. Can you evaluate the claims of those who might expect to benefit from the estate? Do you know who your family are, who might be expecting to benefit? You should know at least that information. And if there's any conflict, you should know a little bit about that and be able to discriminate between competing claims. When one child is saying, no, give me the money, I've been helping you, my sibling is ne'er-do-well and hasn't helped you, we can talk more about that. And four, are you capable of communicating a clear and consistent rationale for the distribution? This is especially important when there's been a will change from previous wills. People make multiple wills, and they're entitled to. And you're entitled to distribute your assets in any way you want in Canadian law. There's no, unless you have a dependency claim, which is another issue. But if you have adult children who are otherwise independent, you're not obliged to give anything to them. You're not obliged to treat it equally. You can do what you want. But if you're changing your mind, if it's a departure, you should be able to explain what you're doing. And finally, this is the important part when it comes to psychiatrists. The law says, and it's based on the original Banks and Goodfellow test, because John Banks was a mentally ill person living in a mental hospital in England in the 19th century. And he was deemed capable because even though he had chronic schizophrenia and multiple delusions, those delusions did not influence his decision about his estate distribution. And the judge wisely said, okay, he might be mad, he might be crazy, he might have delusions, but it's not influencing the disposition. But if you do have a delusion or a disorder that makes you paranoid about one of your children, and you're changing your will on the basis of a delusional belief, you will not be capable according to the law. Okay? So that brings me to the difference between the definition of a delusion in medical terms or in legal terms. Interestingly, the law actually tries to define delusion, believe it or not. And despite the fact that I said judges know nothing about cognition and about psychiatric disorders, they've given opinions about delusion. The first bullet point is the traditional. I favor this. I know that DSM has other definitions, but I favor the medical definition of a delusion as a fixed false belief out of keeping with one's cultural, and now we add political because of what's going on in the United States, cultural, political, educational, religious background. That's what a delusion is. And it's usually, almost always, associated with an underlying mental disorder. Now, sometimes that mental disorder might be a delusional disorder itself with no mood disorder and no other psychotic symptoms, but most often delusions are part of another mental disorder. And that's where you as a psychiatrist can help the court understand the context. Interestingly, bullet 2 is the way the law defines a delusion. They define it as the judges have ruled that a delusion is an idea you can't conceive any rational person to believe, right? So that's problematic with the way the law defines delusion, in my opinion. And in fact, the law, interestingly, refers to delusions by the term insane delusion. That's how case law describes it. They use the term insane. That's from the 18th, 19th century, and it continues even to this day. I was involved in a trial recently where the opposing counsel insisted that it was somebody who had mild cognitive impairment and was getting suspicious about a daughter-in-law. The daughter-in-law is usually the object of most delusions and dementia and stealing delusions, as you know. And yet the lawyer was stuck on this term insane delusion. And I've tried to encourage judges and lawyers to stop using that term. A more appropriate term based on the legal test is a dispositive delusion, a delusion that influences the disposition of the estate. That's the definition of a delusion. Now let's just talk for a minute about undue influence, which is almost always alleged in cases where capacity is challenged. There's almost always a challenge to they didn't know what they were doing, they weren't capable, and they were unduly influenced, usually by one child or another, or by a second wife, depending on the situation-specific factors. You have to know that it's not illegal or unethical to try to influence somebody, to give you a gift or to hand over their assets. There's nothing wrong with saying to a parent, you know, I've looked after you. I think I deserve to get a little bit more because of the sacrifice I've made in the years I've lived with you. My other siblings have not. That's not necessarily undue influence. Undue influence is not generally a one-time act. It's usually manipulative behavior. It almost always happens behind the scenes. Nobody sees what's going on. But ultimately, it really refers to unfair persuasion in the context of a specific relationship, often a dependent relationship, and often in a vulnerable person who. So if somebody is vulnerable, cognitively impaired, and you start influencing them by pressuring them, by threatening them, that becomes undue influence. So the definition here is excessive persuasion that causes another person to act by overcoming their free will. The term subversion of will is probably a better term than coercion. You don't necessarily have to threaten somebody with physical violence. It's actually just yet another form of financial and emotional abuse. So it's a form of abuse, undue influence. So that's also another reason for we as geriatric psychiatrists or geriatricians to know about this issue. What makes you vulnerable to influence? Well, a lot of common disorders, including mild cognitive impairment. Just a little bit of impairment can make you more vulnerable. How do you sort out competing claims? How do you sort out what's going on in your environment? Obviously, dementia and even frailty alone, the frailty syndrome can make you more vulnerable. What are the exploitable symptoms? Well, memory loss. If somebody's got dementia, they don't remember whether somebody visited or not. They could easily be convinced, oh, you know, my other sibling has never visited you, and I do. They don't remember. They've developed BPSD in the form of suspiciousness or delusions, as we just talked about. And the other is the frontal executive dysfunction that's associated with many cognitive disorders, where you lose the ability in your frontal executive functioning to discriminate what's going on in your environment and to discriminate claims. So those are the things that you as an expert specialist can bring to the table. And here's another illustration of the paradigm graphically. Again, it's black and white. If the question of undue influence is the influence is either not undue, that it's still appropriate, or it crosses a threshold of undue. And where is that threshold? Well, it's a changing threshold again, based on the interaction between the y-axis, the level of cognitive ability, and the x-axis, which is the amount of coercion or influence that's being exerted. And again, you see here, if you go to the high end of cognition on the y-axis and then go across on the x-axis, you see that you don't get to the undue influence part until it's extreme. And theoretically, any of us who are supposedly have intact cognition. If we were kidnapped and threatened with a gun, that level of coercion would probably make us change our will. That would be undue influence. But it would have to be pretty severe in a cognitively intact person to be considered undue. Whereas, again, if you go down the y-axis in terms of cognitive vulnerability, and then you go across in terms of the amount of influence, in a cognitively vulnerable or emotionally vulnerable person, it doesn't take as much influence to cross the threshold where you're subverting their will and they're unduly influenced. So that is conceptually the way I would address undue influence. Some clinical red flags for you to be aware of. Well, first of all, great age alone. And great age, let's remember, is not 65, it's not 70, it's not 75, it's probably not even 80. So great age doesn't become an issue until over 85. Where there's been a very significant change. Somebody's had a will for many years and all of a sudden they're changing the will. That's a red flag. You have to be able to determine that they can explain. They can change the will, but they have to be able to give a clear rationale. Deathbed transactions, especially where there's a high prevalence of delirium, have to be suspicious, right? A lawyer runs into the hospital room at the last minute with a will kit, changes the will, that's suspicious. When family express concerns, and you know this as well, that when family express concerns, you really need to pay attention. They're the ones who know whether there's a change in cognitive ability. Their explanations are often wrong, their attributions are often wrong, but when they say there's a change, I think generally we can believe families. When you know that there's a known cognitive disorder present, that's a red flag. And finally, the opposite of a red flag. Social graces. As you well know, many people with often severe dementia can preserve social graces and look on the surface to be intact, pleasantries, chit chat. They don't look obviously impaired. And I can tell you that I've been burned many times when I don't actually do a formal cognitive screening test on an elderly person who comes to me for a consultation, because if you don't probe very specifically, it's very easy to miss significant cognitive impairment. So another thing that lawyers want, and I'm going to try to go through this quickly because I don't need to explain to this group about cognitive testing. This is something that I talk about to lawyers and to judges. But cognitive screening tests, whether we're talking about the MOCA, whether we're talking about the MMSE or other cognitive screening tests, do not determine whether somebody is capable or not. The tests are not diagnostic. The diagnosis doesn't tell you whether they're capable. All a cognitive screening test does is it does two things. It can corroborate the level of impairment that you are assessing and that you're going to describe for the court or for the lawyer. So if I say this person has got a severe dementia and they really don't understand the relevant issues, and their MOCA score is 10 out of 30, that is corroborative. The 10 doesn't tell you that they're not capable necessarily, because depending on the situation, they could be. The other thing about cognitive testing, and this is important clinically, but it's important in terms of retrospective assessments. If you have a series of cognitive screening tests and scores, you can tell whether somebody is deteriorating, if that's consistent with a dementia. So looking back retrospectively, their suspiciousness takes on certain meaning if you know that subsequently their scores went down. So that's the value of cognitive screening tests. The brain functions that underlie capacity are part of our cognitive screening. Orientation, can they remember? Is their reality testing intact? Do they have delusions? And importantly, do they have intact executive functions? And I'm not going to go into that today. I'm expecting that you guys know how to test executive functions. I'm just going to show you the clock drawing test because that's just a particular interest of mine and how I explain this to lawyers and to judges. The clock drawing test, as you know, is a commonly used screening test. I use a pre-drawn circle, and here's the instruction. A lot of people don't know this, but the instruction in the clock drawing test is important. This is the way it should be instructed. This is a clock face. Fill in the numbers and set the time to test past 11. That's the traditional instruction for clock drawing. Do not say put in the hands, because that's giving them a clue. Because a lot of people who are impaired don't know how to put in hands. So I'm going to give you some examples. Historically, this series of clocks is what got me interested in clock drawing as a cognitive screening test. And it was originally related to a patient that I saw when I was doing my training in geriatric psychiatry. In a geriatric hospital, I saw a guy who had a stroke, and I saw him on day 1. And after the stroke, he had emotional incontinence or lability. And he drew the clock. That was before I was using 10 after 11. This is many, many years ago, before 10 after 11 became the standard time that we use. So that was the clock on the left. And the geriatricians who had seen him after his stroke when he was emotionally incontinent put him on a high dose. Now, I go back far enough that amitriptyline was the standard antidepressant, and they put him on high dose amitriptyline. That's when I saw him on day 1. And you know that geriatrics has been called the art of taking people off their medication. So I took him off the medication. I went back to see him 2 weeks later. And among all the other cognitive tests, I asked him to do a clock again, just for some reason. It wasn't clear. Clock drawing was not a standard test. It was used primarily as a parietal lobe test of visual spatial function, not as a cognitive screening test. And I could see that he was better and the clock was better. And 5 weeks later, he was way better after he was off the amitriptyline. And I realized that clock drawing could be a sensitive test for cognition. And that's the story of how clock drawing became a cognitive screening test as opposed to a visual spatial parietal lobe test. I don't have time to go into all the details. You guys know clocks. Here's one that shows the typical 10 after 11. They're not quite sure. It points to the 11. They just drew a straight line. There are a lot of different ways people screw up the 11, 10. And I said, this is a clock face. And they weren't trying to be funny, but that was a concrete interpretation of a clock face here. And you can see a paraphasia. When they were asked to write a sentence, they say, I want to go home. That's a paraphasia instead of I want to go home. So that was further evidence of cognitive impairment. I really don't have time other than to talk about executive brain functions. That's always a very important element of capacity. The ability, because the higher level complex tasks like making a will and making gifts involve impulse control, the ability to think abstractly, the ability to discriminate claims, to plan ahead. That's what appreciation is, planning ahead, using judgment. So testing executive brain functions and correlating that with these specific tasks involved in capacity is helpful as, again, a corroborative. If they do poorly on an executive brain function test, doesn't automatically mean they're not capable. These tests are corroborative. That's what they do. And you can see here the frontal lobe tasks that we all use. And again, for this group, I don't need to explain that. The important point here is that many of the frontal lobe tasks involve initiation, and that's where motivation, for example, comes in. We see people with frontal impairment who have apathy. That's because they have trouble initiating, and we use the verbal fluency test. We use the generation of words with phonemic and semantic primes. And the bottom one, response inhibition and set shifting. It's been said that the damaged brain is a sticky brain. And that's why when we do executive frontal lobe functions, we do tests that check whether the brain or the mind is able to shift mental sets. We do go, no go, alternating the Luria test, right? Fist, side, palm. That's alternating movements. The trail making task is another example of shifting mental sets. That's why we use those tests. They reflect frontal executive functions. It's corroborative when you're doing capacity assessments. So in order to leave time, I'm going to summarize. Making a diagnosis of a cognitive disorder or any mental disorder is not the same as having incapacity. a score on a cognitive screening test is not the same as doing a capacity. They're simply corroborative. Capacities are decision, task specific. They are situation specific. You need to know what the particular criteria are for a specific legal test. In the case of making a will, you need to know what the Banks and Goodfellow test is. In the case of for example, granting a power of attorney, you need to know what in Ontario the Substitute Decisions Act says about the test for making power of attorney. Most importantly, you need to probe the rationale that that individual has for whatever decision they're making. Can they provide and communicate a clear rationale for their decision? And most importantly, of course, this is mainly for lawyers who often don't record what's going on. I see lawyers who prepare wills in people who have all sorts of red flags, and they don't document the most fundamental aspects of why they're doing what they're doing. And that makes that will vulnerable to attack in retrospect. So those are the basic elements of capacity assessment, and I'm happy to take questions and have a little discussion until 1 o'clock, our time. So I'm not sure how you want to do this. Should I stop sharing screen? Maybe I'll do that and then we can. All right, so does anybody have any questions about what I've talked about or want me to elaborate? Everything was perfectly clear? No questions?
Thank you, Dr. Shulman, for the presentation. Really appreciate it. Just a quick question about the communication piece. I think I might know the answer to this, but for patients with like a pretty significant dysphagia, what sort of accommodations would be reasonable to provide? Like say they're like not verbal, but would you be able to, provide them options to choose from?
Right. Okay, that's a very good question because it relates to this important issue of being able to document the person's ability to communicate their rationale. And you have to distinguish between a communication deficit and a cognitive deficit. There are various techniques that you can use to help somebody with a communication deficit post-stroke, for example, or somebody with a brain tumor, somebody who has a communication deficit. And there's a technique that is known as supportive communication for aphasia. It's known as SCA. And basically, it involves multiple modalities, multiple methods of determining whether, so just because somebody can't spontaneously, when you ask them an open-ended question, give you a clear answer that you can document and satisfy yourself that they're capable. What you need to do, as in all assessments that you do, you start with the most open-ended question, and that's the highest level of cognition and ability. However, if somebody doesn't respond appropriately or can't, then you have to increasingly structure your questions and make them focused. Now, the danger in structuring and asking specific questions is that you're leading them, and you have to satisfy yourself that they really do mean what they're saying. And so often the way you do it is using different modalities. You can determine whether they're consistent in their answers on repeated questions. So even though they can't communicate spontaneously, they are responding to choices. You offer them multiple choices. How much do you want to leave to this particular child? Is it $100,000, $200,000, or $500,000? If they can't do it spontaneously. And if they can answer consistently, that's another way of doing it. You can use different modalities, not just verbal, but thumbs up, thumbs down, check mark, hand in the air. There are a lot of different modalities you can use to corroborate whether somebody is giving you the same consistent answer. So you start open-ended, start with more structured and focused questions, and use different modalities, sometimes pictures, sometimes, as I said, thumbs up, yes, no answers. But you have to do it repeatedly to demonstrate that they are consistent in their responses in order to satisfy yourself that this is not a cognitive deficit, it's not incapable, it's a communication problem that you can help them with through supportive decision making. Okay?
That makes sense. Thank you so much.
Any other questions or comments?
In a few of the graphs that you'd showed, you'd used cognitive capacity as well as emotional stability.
Yeah.
I'm wondering if you can explain like what that means in the context of like our demographic of patients and what that would look like.
Right. Well, I mean, cognitive, I think, is self-explanatory. Emotional stability, what I was referring to is you need to be able to ensure that the patient, if they're not cognitively impaired, doesn't have a mood disorder, for example, that they're not hypomanic, that they're not clinically depressed and vulnerable for that reason, or have a distorted view of their circumstances because of a depression, a mood disorder, or a paranoid disorder, or any other psychiatric disorder. So that's what I mean by emotional stability.
Okay, thanks. That makes sense.
Okay, let me ask the group here, have you had any other teaching or exposure to capacity assessments? And if so, in what context? And what are some of the issues that you may have had in thinking about capacity assessment?
I had an interesting, we just had some teaching from some geriatric medicine physicians about capacity, and they had talked about an interesting case where a patient, I think, was probably sick with, I don't know if it was a delirium or something, but there was some, oh, actually, I remember now, it was hearing. They had like a severe hearing deficit and they couldn't really hear when they were getting the assessment done. And it was deemed, whatever it was that happened, the son was made the substitute decision maker and had changed some of the financial things and had kind of for whatever reason, like was deemed to be getting some of his assets and things. And then after the fact, once he got his hearing corrected, he sort of challenged that decision and kind of then they had to kind of went to the courts and everything. And he wanted to get like ownership of his cabin and things back. And I just thought that was an interesting story that like hearing of someone challenging it themselves after they had sort of lost capacity and then deemed to kind of get it back once the hearing was corrected. So I thought that was an interesting kind of case and story.
Yes, that's a very interesting, and you make a good point that I didn't really mention, and that is sensory impairment in terms of communication. You have to ensure that that they can hear and see things properly, and that's not the factor. So it's not just speech communication, but you're right, hearing is an important component of that. So thank you for highlighting that because that's another element of communication
Yeah,
as
it's
opposed to
interesting.
cognitive.
For sure. And I think this one, it just so happened that it was during COVID. So a lot of the like court proceedings were virtual. And I think a lot of that was even more difficult for the hearing too. So those kind of factors that, made him seem less cognitively well than he was.
Yes, very good point. Thank you for bringing that up. That was good. Any other experiences or concerns about doing these assessments or acting as a medical expert? No concerns. So am I right that you guys have not had very much in the way of formal teaching or experience with capacity assessments?
At Dalhousie, where me and Alec are at, they've set up some like a workshop every year or two that they're going to be doing with geriatric medicine. So that's been really quite helpful. And I had a recent interesting experience with a patient who a lawyer wanted all domains of capacity to be assessed, including involvement in recreational activities and who they could associate with socially. So that was a new experience. And actually, those things were preserved, her capacity around social and recreational activities, but other domains were impaired. So that was interesting because her like previous values around relationships were preserved and she had good judgment around who she was associating with. But it was interesting to try to ask questions around those aspects because usually I'd just done medical, financial, and personal care related decisions and not those other domains that are on our Form 1 form in Nova Scotia.
You're right. You're right. That's so it's important that if you are asked by a lawyer to opine on any capacity, it's important that they communicate to you what the test is. You need to ask them, you need to direct me, you tell me what the test is for this particular capacity, and I will do the assessment to determine whether this individual is able to meet these criteria. It's not for you to determine what the test is. So, and as you say, it's very decision or task specific. I mean, there's capacity to marry. You could be asked about that. Well, what's the test for capacity to marry? And I can tell you that's very problematic in the courts. You know, capacity to gift, capacity to make a will, capacity. These are all different capacities. So, again, a lawyer shouldn't be asking you to say, just tell me about all their capacities. They have to be very specific and direct you about what the test is.
Yeah, it seemed quite odd, honestly, but it had been quite a long saga with this patient, and I was coming in sort of late. So we did check everything, but it seemed excessive, honestly.
Right.
Yeah, because she was going to be going to a nursing home and in quite a controlled setting anyway.
Correct. Right. Well, the capacity to consent or refuse long-term care is another very specific capacity. Often there are designated capacity assessors in the long-term care sector who do that rather than something for us to determine. But that sometimes varies by province. So any final questions or comments? I see it's just about end time here. All right. If not, thanks for your attention and good luck to all of you. If anybody wants to communicate with me afterwards, if you have a specific comment or question or experience, I'm happy to engage. Okay. All right. So is somebody going to end meeting or am I doing that?
I can do that.
Okay.
Thank you so much.
Okay. Bye-bye.
Thank you.
Bye-bye.